My name is Tom Goddard. I'm the CEO and founder of Integral Healthcare Solutions. Welcome to our webinar. This month's webinar is focused on standards that are issues that cause our URAC accredited or applicants for accreditation extra issues or extra problems. And joining me today to talk about these tricky standards are my colleagues, Carole Crawford and Lesley Malus Reed. We're delighted to have Carole join us for the first time. Carole is relatively new to Integral Healthcare Solutions, but not new to us. She's been with URAC before she joined us for quite a number of years. And is a good friend of ours and now a colleague, and we're delighted to have her here. And of course, Lesley goes back to the beginning, or very nearly the beginning of IHS. I'm going to let Carole and Lesley introduce themselves, and then I'll introduce the topic a little more fully, and we'll dive right in. Carole, who are you? And tell us about your background.
Well, hello. Yes, I'm Carole Crawford, URAC reviewer, or was a URAC reviewer. Missed that. I am now proud to be an IHS consultant. And thank you, Tom, for the lovely introduction. I've been with IHS for just about 3 or 4 months now. And prior to joining Tom and Lesley and the others, I worked at URAC for 11 years. Before joining URAC, I worked for a large health plan in California doing accreditation work there for about 15 years. And I am a registered nurse by trade. So thank you. And Lesley?
Hi, I'm Lesley Malus Reed. I'm president at IHS, and I come from the Canadian healthcare system. I joined URAC in 1997. And since 2003, when I joined IHS with Tom, I started helping applicants get ready for URAC accreditation and have really enjoyed that. I am very excited to share with you our experience and knowledge that we've gained over the past several years. Tom?
Thank you, Lesley and Carole. So by training, I'm a lawyer and an industrial organizational psychologist. I joined URAC a year after Lesley did in 1998, and a year before Sue DiMarino, our chief clinician, did in 1999. And was with URAC for a couple of years and then started this company in January of 2002. And so for 18 and a half years have been working with applicants for URAC accreditation and other accreditations as well, ACHC, Joint Commission Specialty Pharmacy, VIPS as well. And so in a sense, you participants and viewers of our webinars are at least in part responsible for the topic this month, and that is how to navigate URAC's trickiest standards. Because in your feedback to us, you said, well, we want to have this covered. We want to know what things to really worry about. So we're going to cover tricky standards that, particularly at either the desktop review or validation review phases of the URAC process, it caused many of our clients over the years to stub their toe or to have to work a little extra harder than other standards. But also we're going to take an opportunity to cover some standards that are simply new and seem likely to cause issues for even veterans of the URAC process. And that's a big and developing topic. We're gaining more and more information every day about new interpretations at URAC, and we've had a wave of new interpretations lately that we'll talk about both later in this webinar and in an entirely separate webinar, kind of the new way of looking at your application that we're seeing URAC take. Many of you have asked over the last few months for a special session on the trickiest standards in the URAC process. So we're going to focus today on the trickiest standards, both those that have historically been the cause that a client or two or maybe multiple clients have stubbed their toes on them because they're just hard to do, or perhaps some recent interpretations, or maybe they're new standards that require a bit of extra effort or thought. So we're going to cover both of those topics. Now, that second issue of new standards or new interpretations, we're going to dedicate a future episode. We'll talk a bit about that in this webinar, but we're going to dedicate a future webinar to a wave of new interpretations that we're experiencing now, or our clients are experiencing. Some of them are new interpretations of older standards, and some are new interpretations of relatively new standards. And we're going to focus an entire episode on that. So you'll get a touch of that today, but generally we're going to save that for its own episode. So let me share my screen here, and we'll dive into our substantive presentation. All righty. So I'm going to toss this first a couple of standards to Carole, core and core-like standards, policies and procedures. Carole, take it away.
Thank you, Tom. So with URAC, all of their modules or products are moving away from the old core and module format. Core will be going away as we have known it, but the standards will be rolled into a new format with sections called focus areas. And under the focus areas are the standards, and then under the standards are the elements of performance where the scoring will take place. And you will see a sampling of how the standard format is changing today in this webinar. So the first one we're going to talk about is the core 3 in the old format was called policy and procedure maintenance, review and approval. The new version is called OPIN, O-P-I-N, and that is 2.2. It's called maintaining and complying with policies. What is new is the definition of annual. Annual occurs every 12 months to the month, not the day, but just the month. So for example, it would be October 2019, October 2020, October 2021. You also have the option to, and rather than doing it month to month, year to month, year, you can do it the same quarter each year. If you opt for doing it the same quarter each year, you must have a policy and procedure that documents that chosen method and have that policy approved. The other new standard is that new policies and procedures are reviewed at least every 36 months. It used to be annual. It's now every 36 months to the month. And if changes are made, you must be sure to document that the changes have been disseminated and communicated to staff and made effective within that 6-month time frame. Not new is the requirement to comply with your own policies and procedures. If 3 or more numerically weighted elements across 3 or more separate elements of the performance are not met, then compliance with the mandatory element B will be rated as not met. And I think that's it for policies and procedures.
Yeah, Carole, let me just double check. Let me just double check my understanding on this. So for our existing clients who are going through reaccreditation, whose policy that they established to comply with Core 3 says review annually, they're going to be held to that unless they change the policy to say every 36 months. Is that a fair reading of this?
That is correct. For new accreditations, that probably would not apply because URAC looks at new accreditations from what they call the index date, which is the date the application is submitted. But for clients who are going through reaccreditation, the URAC reviewer will look back 3 years to make sure that the policies have been approved annually for the past 3 years. So
and so that if you do want to take advantage of the 36-month thing, make sure that you change your policy so that you're complying with your policy when you switch to the 36-month piece. Got it.
Yes, when you change, if you choose to go to every 36 months per policy, it would be on a going forward basis from the date that policy was approved.
One more tricky thing I'd like to discuss about this standard is that URAC allows, part of the standard says that in a policy, you must demonstrate effective dates. revision dates, and the approval authority. And URAC allows that to be demonstrated either in the policy or on your master list. And your policy should describe where you're going to demonstrate this. In the new version, OPIN 2-2, if it is not included in your master list, they want you to submit 3 examples of policies and procedures to show that you are listing the effective dates, revision dates, and your approval authority.
Got it.
Thanks.
I'm going to move on to what used to be called, and still is for many of you, Core 4, and for those of you coming in under the new versions, RM1-1, Compliance and Codes of Conduct. Now, this is where we're starting to see some new interpretations that quite clearly are starting to raise the bar, raise expectations about levels of documentation required for demonstration of compliance with the standard. And that typically happens when URAC goes from one version to the next. And this is certainly no exception to that trend over the 20 years we've been doing this. With respect to these standards, you need a good deal more detail than you may have had to submit in the past. If you don't describe in detail how your organization tracks laws and regulations or conducts monitoring and auditing, you're more likely to get a comment back on your RFI. You can't just say such and such an organization tracks state and federal laws that apply to this organization. And in fact, while it helps to say the director of compliance will track, URAC is being very rigorous about saying, well, how do you do that? Do you subscribe to newsletters? Do you keep this in a database? What do you do with that information? How do you disseminate it to the right people? So that's on the tracking of laws and regulations. On the auditing, you can't just say we do ongoing monitoring and auditing. You've got to say, here's how we do that. And then this next piece has been going on for a while, but I'll just emphasize it here. You can't simply say we respond promptly when we find that we are out of compliance. By prompt, we mean 24 hours or 35 hours or whatever it is. You got to describe prompt. That's not new. Now, what is new, and we're not sure that this will stick, but this came back in a recent request for information from URAC. And that is the reviewer wanted to see that expressed in terms that you might see on a quality improvement project. That is, the term used by this reviewer was a measurable metric. And the example that reviewer gave was 95% of our responses will be within 36 hours or 24 hours of receipt of information that we've been out of compliance. We've never seen that before, and it's too early to tell whether that is an outlier or that is a formal new interpretation. We'll probably need to see a few more RFIs to see if that is if that will be applied consistently. But just know that it may be that you need to express in your policy your notion of promptness in something that could stand the scrutiny within a quality improvement project. So stay tuned for more interpretation of that. Now, moving on to the auditing piece, we've noticed a good deal of a struggle about how to describe the auditing requirement. And and you may actually need to describe multiple auditing mechanisms because you have this kind of auditing for a certain kind of compliance with certain laws and regulations or your code of conduct, and a different auditing mechanism for others. And feel free to use all the detail you need so that the URAC reviewer gets a very clear idea of who's doing what and how when you conduct your auditing for compliance. Now, also in this category of standards that's new is RM1-2, the whistleblower standard. This is brand new. And while many of our clients already have a whistleblower policy, even they need to go back and review it to make sure it complies with the new RM1-2 standard. We don't know if this is going to be tricky, but it will certainly be new for some of you. And even if the idea is not new, URAC has a very specific notion of 3 major components that you need to deal with. I won't go into the details on that. It's fairly clearly expressed in the standard. But one of the 3 components is you've got to describe how you protect confidentiality of the process once somebody has reported a compliance concern appropriately to your organization. Another new standard in this bucket of standards is CPE 1-1C, incidental contact with PHI, IIHI. We've not seen this before. Basically, the way I think about this is that this is a component of your HIPAA policies that contemplate that you might have a different set of protections of PHI and IIHI when it comes to protecting it from, let's say, cleaning services. These are folks, vendors or employees that don't actually handle or come in direct intentional contact with PHI or IIHI as a part of their work, but they might be in the vicinity. And so you might have a different set of requirements for the protection of your confidential information for those folks than you might for your employees or contractors that are actually handling the PHI and IIHI. So I just wanted to highlight that. It is a new standard and that you've not seen before in the URAC standard. So I encourage you to kind of look carefully at that. My guess is, and again, it's a little too early to tell, my guess is that if you have the same standards for everybody that's coming in contact with PHI, whether as a part of their job or just incidental contact, then that's fine too. And you'll just submit the same policies for this standard as you would for others. But it may be that you have a separate set of protocols regarding how you deal with vendors that kind of are in the neighborhood, but not actually handling PHI. So now we'll move on to the next standard.
Another new standard is OPIN 1-1, Code of Ethical Business Conduct. The first element to this simply says your senior leadership must adopt it. Well, how do you prove that? Well, you have a meeting, take minutes, and show them adopting it. Also show them somehow, URAC also wants to see how you convey that code of ethical business conduct once the leadership has adopted the code. And I won't go into detail on this, but make sure that your code, just because you have a business conduct code doesn't mean it complies with this standard. Look very carefully at the sub-elements here that have these 4 specific issues specifically mentioned. Agreed upon principles, expected and prohibited behavior, again, a reference to this new whistleblower requirement. And what are the consequences if an employee or a delegated contractor violates the code of ethical business conduct? Now, this standard is not to be confused with this next standard, which I'll toss to Lesley to start out, OPIN 3-2.
So there's OPIN 3-2, which is the old training standard. That's the old Core 27, and it requires that you have folks be trained in certain topics. And there's a lot of differences in the new set of standards for specialty and mail service, especially pharmacy mail service, case management. So as URAC is revamping it, they've put in some new requirements. The one that seems to be the trickiest for our clients to meet is this new requirement that in addition to a code of conduct, that people have training in ethics in healthcare practices. And a lot of our clients are saying, well, it's in the code of conduct. But actually, there is a standard CPE 2-2 that Tom will talk about. And the topics in that standard, those are the topics that are looking for training in OPIN 3-2. So once you have a good understanding of what's required for 2-2, what defines the scope of ethical healthcare practices, turn that into training to ensure that all staff receive it. Tom?
Yeah, I don't have an awful lot to add about CPE 2-2 and 2-3 other than to say this is brand new. and you're going to have to go through each of these 4 or 5, depending on the program that you're coming in under, elements that are required components of the ethical healthcare practices code. So, so just be really diligent as you read this standard and take it literally. That's one of the things that we're quite clear about these days, is take both the standard and the interpretive guide literally. They are, URAC is absolutely enforcing what you will see there in writing, even if you kind of scratch your head and say, well, they've never enforced that in the past. They've never had that level of detail. They are now. So be very, very attentive to that. CPE 2-3 is a partner to 2-2, and it's basically, it's a new standard, and it requires that you monitor compliance, have mechanisms to monitor compliance with your code of ethical healthcare practices. Again, you're going to need to start from scratch if you don't have a code of ethical healthcare practices in place already, in both the establishment of that code and in the monitoring mechanisms for that code. And now delegation. This is delegation, as I think we've mentioned in earlier webinars, but it's worth repeating here. Delegation is one of the more interesting and for some organizations problematic standards, because on the one hand, basically it replaces the old core 6 through 9, and now it's all in core 9, or in the newer standards OPIN 4. So, and the core 9 and
All right, so Tom, while he gets back his audio, I'm going to take over a little bit here. So, what now is in
needs to be in the
9.
contract, not there.
Tom, you were broken up for a little bit, so I'm going to ask you to repeat what you just said.
Sure. Sorry about that. Well, it may look like I'm in Sedona. I'm actually not out in the mountains right now, but still have shaky internet here. So the delegation standard kind of looks like it's an awful lot less than it used to be the last time you went through if you're a reaccreditation applicant, but it's actually more. In almost every respect, it's going to require significantly more documentation, significantly more activity and oversight. And so this is where I cannot stress too much your reliance on the interpretive guide, and if you're a client of ours, also on our tips and tricks that we provide all of our clients. URAC requires that your contracts need to specifically refer to what URAC standards you're requiring your delegated contractor to comply with. So if your delegated contractor is doing functions that are addressed by, let's say, your health plan, your credentialing, PCR 1 through 17, then your contract with them, or so it appears from recent RFIs, needs to specify that. The delegated contractor will perform these functions in accord with PCR 1 through 17, or all of the PCR standards, URAC standards.
So what you're saying is that it's no longer enough for them to write that they will meet URAC credentialing standards. They actually have to state the number of the standards.
That's what it appears from very recent RFIs that our clients have received. Okay. We, for quite a time, it was fine to simply refer generally to your applicable URAC standards. But it appears that at least some, and we have reason to believe that most or all of the URAC reviewers are now requiring that specific level of detail. And, you know, we shouldn't be too surprised, because if you look at the actual language of the accreditation guide, it's in there. It says list those things. Now, what is particularly new generally is that you've got to have unless it's a URAC accredited delegated contractor, you've got to have a compliance rating tool. And it's got to be quantifiable stuff. So let's say you're reviewing them across 18 different things, turn that into a number so that when you execute your tool, you can see, well, they got 16 out of 18 of those components right. Now, again, in a very recent RFI, it appears that you're going to be required to correlate the applicable URAC standard to the component of the rating tool that is assessing their compliance. Now, again, we've never seen this before, but we're seeing it now. And again, we shouldn't be all of that surprised because, you know, the standard's been out for a couple of years in this form, and kind of written into it is this new philosophy at URAC that if you're going to delegate certain URAC relevant functions, then you have to act like URAC will. And in fact, in the interpretive guide, you'll see that they say, the URAC says, if you're going to require compliance with, let's say, PCR 4, then you need to assess your delegated contractor's compliance with PCR 4 the same way URAC would. Review the documents and do some sort of validation review just as URAC would. And so now we're seeing that kind of manifest in interpretations of this element about the compliance rating tool. So whatever you've done before, likely, if you do delegate, likely is going to need to be upgraded, not just in terms of the documentation that you show, but also in what you're actually doing, and your policies and procedures, and your compliance rating tool. And here's something that's not new, but we're still seeing applicants miss this. No standards are rendered not applicable merely by delegation. The pharmacy benefit management related standards within the health plan standards are a classic example of that, where a health plan will delegate their pharmacy functions, their formulary development, and all of that to a major PBM. But even though it's not new, we're still seeing applicants, our clients, miss this issue, not quite fully understand that. So that's why we stress it here. Now I'll toss this back to Lesley.
Thank you. This one's all me. So this is Core 25C, which is also OPIN 3-1B3. No changes in what's required in the new set of standards. But it is a tricky one for a lot of our clients to meet. This standard requires that within your job description, if you have clinical staff who require either a clinical license or certification, there has to be very specific language for what's required. You must have the language that the license or certification is either active or current, you could use either word, and without restrictions. What's new now is some of the reviewers are saying in the state of X. So active or current without restrictions in the state of X. It's supposed to be in the state of X if your regulations require it. For example, in case management, you must have a license in the state in which the patient, and we'll talk about this later, is receiving services. So there it is necessary, but there are for example, the specialty pharmacy standards. In some states, your pharmacist must have a license also where your patient is going to receive their meds. So they might need multiple licenses, and you're going to have to track and trend that. So some reviewers are going to ask you, is it in the state of X? We're recommending that you work with compliance and ensure that you understand what you're required to do. If it's no big deal for you to just start off by saying in the state of X, then we encourage you to do so. While we switch to the next slide, I also just wanted to touch upon, we had a couple of questions. If you have a question, you'll see as you scroll down a chat section. Please ask us any questions. We're happy to answer live in between sessions about anything that we're talking about. 2 questions we got was, will the slides be available? If you are interested in the slides, please, 1, know that we are recording this session and it will be available on our YouTube channel in the future. But 2, if you like the slides, then you can contact Kristen Peterson at our offices directly via email, and she'll send it to you. It's K Peterson, Petersen at integralhs.com. So K Peterson at integralhs.com if you just want the slides. All right, I'm passing it to Carole for quality.
All right, thank you, Lesley. So the main thing in quality is sort of like who does what. There's seems to be confusion when we're doing the validation review in demonstrating approvals. So for example, in PMI 1-2, you're required to periodically evaluate the effectiveness of the QM program. And again, I'll reiterate what Tom said, you have to be very literal because this standard applies to the QM committee itself. This is a change from the annual evaluation. But again, you can define it, your time period. However, PMI 1-5 imposes an annual reporting of the effectiveness to leadership. So this is where the difference comes in. The first part of this standard requires effectiveness be evaluated by the QM committee, but PMI 1-5 imposes reporting of the effectiveness to the organization leadership. And leadership may not always be the quality committee. The quality committee may report up to leadership, especially in a large organization like a health plan. But if you're a smaller organization, such as a specialty pharmacy or case management, leadership may be the quality committee. So that's just some clarification there for you and how you write your program and what you present to your URAC reviewer during the validation review. PMI 1-4 is data management and performance reporting. Again, you must have quantifiable requirements. When I see the word quantifiable, I think numbers. You've got to have numbers, numbers that you can record and measure and track and trend over time. Part D of this standard requires that the standard drive the scope of which measures you report. For example, in pharmacy, pharmacies are required to report near misses. If you're a health plan, if you're case management, utilization management, this near misses does not apply to you. What we like to see is a dashboard that includes all of the reporting requirements, the clinical requirements, the non-clinical, the service, whatever measures and metrics you track, put it on the dashboard and upload that to us to review, and also have it available for URAC to review. This shows your key performance measures, and it puts them in a visible format so that it's easier to see and act on the data when you're not reaching your benchmarks and goals. And your data must be accurate and validated. This is CPE 1-2 information management and Plan Ops 3 system requirements, which is reporting measures to URAC. So you have to make sure that you're validating your data, that your data is accurate, and have a policies and procedure that you can present that demonstrates how that's done. Not just a statement that says you validate it, but URAC will want to know how it's validated and who is validating it. And I'm going to turn over technology then to Tom.
So business continuity, let's start with the business continuity piece. And of course, with business continuity, we're all kind of thinking about COVID. How are we responding in the era of COVID? Now, if you're still functioning under the old standards, that is standards that haven't been revised in the last couple of years, last year really, or 2 years in the case of case management, you remember that the test of your business continuity plan must be scheduled and must be live. I mean, it can't be just a tabletop test. COVID, simply coping with COVID under the old standards, which are current for many of you still, does not count. You have to say, okay, on this date, we're going to shut this system down and then see if we can reboot it, or we're going to see if we can restore this backup, or clear out the building. Now, this is a change. This has been changed in the new standards. So if you're operating under the post-Core 4.0 standards, then both of those things change. It can be COVID can count as a test of your BCP, and you also can count tabletops. So just know that there's an easier day down the road if you're still under the old standards. It gets a little easier to demonstrate that you've actually tested your business continuity plan. Now, risk assessment. This is the old Core 15A. And again, that depends on which version you're doing this under. Under the old version, Core 15, the biggest issue is the documentation of how you've implemented your policy. And as we've told our clients for several years now, you not only need to have a policy that describes your risk assessment, but actually either an example of, and you can blot out the results if you're worried about sharing the results of a risk assessment, which many understandably are, but some documentation that in fact you have conducted a risk assessment. Now, if you're a first-time applicant, then it's going to be important that you show that you're about to. When you submit your documentation for desktop review, let's say you submit that today in mid-October, then you'd want to say, and we're scheduled to conduct our risk assessment by November 7th, just so long as it's sometime before the URAC validation review. Now, under the new standard, which is in the new standards numbered RM 3-1, way more, in the standard itself, way more specificity as to what you need to include within your risk assessment. So go through that standard point by point. Don't assume that just because you passed 15A 2 or 3 years ago that you're going to pass 15A with that same old unrevised risk assessment. Go through each one of the many points. It's a much more elaborate standard now than it used to be. You're going to need to review your actual policy, and you're going to need to review your actual security risk assessment tool. Now, here's another thing that is going to be really important, and we've seen this come up very recently in requests for information, that your policy needs to make it absolutely clear that the entity conducting the security risk assessment has zero stake in the outcome of the assessment. Even if you know in your mind that this department over here is not responsible for the actual management of the risk, if that's not clear from the policy and the procedure, you have to put yourself in the shoes of the URAC reviewer. If the URAC reviewer cannot tell with clarity that that entity over there, either internal or external, has no stake in the outcome of the assessment, then you're going to have that sent back to you on request for information stage. It's just got to be crystal clear. To reiterate this last point here, if you're a first-time applicant, make sure that both the security risk assessment and the business continuity plan testing have been completed by the time URAC conducts its validation review. Out of habit, we still call it the URAC visit, but even though URAC's not visiting these days. So, but before the URAC validation review, you got to make sure both of those things in the IT world have been completed and that you've documented it so that during the validation review, the URAC reviewer can take a look at that documentation, demonstrating implementation. And now I toss it to Lesley.
So I just wanted to take a step back for a moment. We just touched upon the core-like standards. And in our old modules that some of our clients who are all listening now, or folks who are going for accreditation, maybe not our clients, we want you to know that there are still core standards that are out there. And these are heads up for what standards are going to be coming up. So the new modules that URAC released are out. And this is the types of things you can expect in terms of differences. In health plan, we know that URAC's working on those standards. There's going to be more revisions. Of course, we don't have a crystal ball to know if they're going to be the new standards, but it's often a hint for what's coming down the line. So just heed what we're talking about and start thinking in these terms of code of business and risk assessments and things like that as we, code of ethics, I'm sorry, as we move along today. Now we're going to get into a more specialized area and touch on a few standards in each of the modules, or some of the modules that we picked that we find are tricky. I'm going to speak right now to the 4.0 specialty pharmacy and mail service pharmacy. The first standard that is seeming to be tricky and has been for all of our clients is the thermal mapping standard. It's PROD 1-1H, and an example of this might be evidence demonstrating thermal mapping of a storage area within the pharmacy. Now, to be honest, it's a leading indicator, and a leading indicator means that there is no weight associated with this standard. There's no points, it's not mandatory. You can choose to meet it or not. And honestly, it's a time-consuming and expensive endeavor to do this standard, to comply and to just try and come up with the evidence and measure it. And most of our, actually not most, every one of our clients so far has chosen not to meet this leading indicator. So you can choose to make the standard not applicable. Whenever you choose to not meet a leading indicator, make sure you submit an attestation signed and dated on letterhead by a senior management representative to state you choose not to meet this standard. You don't have to give an explanation, but you do have to give an attestation to state you are choosing not to meet it. SP Ops 8-2 is qualification testing for all methods of shipping medication. This is new and it's a little bit tricky. They want you to measure refrigerated temperatures, ambient room temperature, and frozen. Now, the ambient is tricky for some of our clients, and the tips we have for you is just to follow your same protocols that you've been doing for your cold chain. You must validate the testing internally, even if a vendor provides their testing. URAC also wants to ensure on that fourth bullet down, each delivery method used needs to be tested: postal, FedEx, local courier, and it requires in the standard for you to have multiple testing. So we're recommending that you test each of those at least twice. The next bullet requires testing results for each package type and size. So again, that's 2 tests for each type of package and size: the packing in, the packing out, your process. So if you use ice packs, bubble wrap, these are all things that you need to test. You should be monitoring the date shipped and time and duration in distribution, the temperature results throughout your shipment, the geographic location that you've shipped to. And again, just to reiterate, it's the delivery method. So you need to do this for both your local courier that you're using and maybe your FedEx. All right, next slide, please. PBM CSCD 7 and 8. And for those who are still coming in under the old SP and MSP 3.2s, this would be your CSCD 6, 5, and 6. This is a disclosure standard, and it has to do with your contract with your third-party payers, your health plan. And it's really talking about what is in the contract. So the first question I'd like you to think about answering is, does your organization initiate the contract? Do you own the contract? So I might be initiating it with Blue Cross and Blue Shield, for example, but I'm going to be using their contract. So if it's their contract, you really don't have as much say in what's in the contract. And URAC says, if it's not your contract, then these standards are not applicable. Submit an attestation to say you didn't initiate it. So that's the first question to answer. Next is, if I answered yes, it is our contract, well, now I need to make sure that I have a policy and procedure and a contract. Now, there are very specific requirements that URAC is saying that you may choose to disclose in your contracts the following elements: conflict of interest, source of revenue, pricing structure, which includes rebates and administrative fees, and whether you're sub-delegating relevant scope of URAC standards to a sub-delegate. If the answer is in your own contract that you initiate, no, you aren't going to disclose these things, then again, this standard is not applicable to you. If you do, then you need to have a policy and procedure that describes which of these standards are addressed, and it needs to describe, you need to have a template contract that describes which of these elements are going to be disclosed in the contract. CSCD 8 is the allowance of the payer, if you will, or the third party to come in and do an audit of what you agree to in the contract would be disclosed. And you can agree to a third party to come in and do the assessment, or you can agree to have representatives from the actual health plan to come in and do the assessment. But that's what CSCD is about. So if you answered, no, we don't do this, or no, we don't own the contract, then this standard is also not applicable. And you would submit the same attestation stating the standard is not applicable, we don't own the contract, or we don't address these standards. Okay. Next slide. Oh, now it's up to Carole.
All right. Thank you, Lesley. So some more tricky slides. This is HUM 16, prospective, concurrent, and retrospective drug review. This standard applies to all drugs. What I have seen in the past is an attestation stating that the organization does not do drug review because they use a PBM. Well, there are many drugs that are not included in the PBM benefit that the organization does review, that requires medical review. So this standard cannot be not applicable if your medical director or your physicians review the drugs that are not included in the PBM. The only time that I've seen it be not applicable is when your organization does not manage any part of the drug benefit. It's a complete carve out. So that is the requirement for that standard. Another tricky one is HUM 18, peer-to-peer conversation. This standard requires that the conversation occur within 1 business day of the request. It cannot be at the convenience of your organization or when your medical director is available, but it can be at the convenience of the provider. And for those of you who have done UM, I'm sure you understand that you have staff that reach out to the requesting provider and attempt to schedule the peer-to-peer conversation within 1 day, but the requesting provider is not available. Well, that's okay as long as you document that in the notes, that your outreach to schedule this call was made within 1 business day. The URAC reviewer will be looking for that documentation. If the requesting provider is not available, that's okay. But if he is available and your physician is not available, then you must find an alternate, another peer reviewer in your organization that can conduct the peer-to-peer call. Another tricky one, HUM 32, lack of information. This allows you to define the timeframes and the process for resolution of cases in which necessary information is not received. You may reach out to your provider maybe once, twice, 3 times. What happens if you don't get the information, if you never get it? Do you go ahead and close out the case and send a lack of information letter? Does the case go on to a medical director to review it with whatever information you do have? Whatever your process is, make sure it's clearly written in the policy and that you follow your policy. HUM 38, expedited appeal timeframe. Even after all these years, we're still seeing policies that say 3 business days. That will not pass the URAC review. It has to be 72 hours. The appeal must be completed and verbal notification provided within 72 hours of receipt of request. So it's important that you document the date and time that you received the request and the time in which you responded with the notification. In addition to that, written notification has to be provided within 3 calendar days to the patient and the attending provider or the facility rendering service. This is a 3-day standard. And I will turn it back over to Lesley.
Thanks. All right, so this is for health plan specific. It's PMR 1, 2, and 7. When you are going to get ready to do these standards, work them together. There's a lot of redundancy in them. And what's tricky about this is that some of our applicants forget that this is not about how you are going to address some of these topics like provider access and availability. It's really about how you are communicating this so that your potential enrollees, members, employer groups know about the topics that are listed in these standards. PMR1 is your marketing safeguard, so it might be what your brokers or your sales are going to explain to your potential employer groups and enrollees. But it has a lot of the same information that you'll find in PMR2, which is what is the information you disseminate once members are on board or potential members also. And then PMR7 is your communication plan. Now, and it also addresses a lot of the same topics about making sure that your communication plan discusses what they're going to disclose to members, enrollees, employer groups. For all three of these standards, you need to submit three things. You need to submit, first of all, a policy that has three things written in it. The policy should discuss the topic, how staff are trained on this topic so that they are accurately portraying your services, and how you're disseminating this information about this topic to the members and employer groups. Then you want to be able to submit, in addition to your policy and procedure, the next two things: training of your staff to show that they can answer inquiries about these topics, and then the actual collateral, such as a member handbook or your website, on how you disseminated this information. So your policy and procedure might state that we are going to provide provider directories via online. And then you would give a screenshot of your website to show where the provider directory is. And you would show that staff had training in provider access. So those would be the policy and procedure, the training, and the member handbook. I encourage you to work on all three of these standards, which I will admit takes me about 8 hours to complete all three of them when I do a desktop review, because they are so redundant, as I said earlier. For example, medical management responsibilities, which is really prior authorization, what your members' medical management responsibilities are addressed in all of these standards that I list here: PMR1E, PMR2G, PMR7C, PMR7D sub-element 1, PMR7E sub-element 3. It's as you can see, it's rewritten so many times, and you could submit basically the same thing for all of them. This says medical management responsibilities again, but what I meant was, I'm so sorry, administrative management responsibilities, which is filing a claim or a complaint, and provider access. Those three themes are repetitive. Next slide, please. Now I'm going to go through a few of the tricky credentialing standards. In Credentialing 1, please know that URAC wants to know what the scope of your provider credentialing program is. The term provider is both practitioners and facilities. And some people are defining the word ancillary as different. Some of them are your non-MDCOs, and for other organizations, it's facilities that aren't necessarily hospitals, acute care. It's up to you to define it as you wish. If the provider is listed in the directory, they must be credentialed, and the provider, again, is more broadly defined as URAC as a practitioner or a facility. There's one goofy thing that's in the interpretive guide, and I'm going to read it to you. The organization, it's the second bullet here. The organization applying for URAC accreditation credentials the individual practitioners providing clinical services in group practice settings and freestanding clinics, even if the individual practitioners are not listed in the organization's provider directory or do not contract directly with the network organization. So what this means is that, let's say I'm in a pediatrician's office, and as a member, I look in my provider directory and I see that Dr. X is in network, and I go and I make an appointment. And when I get there, I see the physician assistant, and then Dr. X comes in and signs off on it. In that scenario, I really only need to credential Dr. X. He's overseeing things. But if I call to make an appointment and the practice says the doctor isn't available, you can see the physician assistant. Well, now the members make an appointment with the physician assistant. In that circumstance, you would want the physician assistant credentialed, because you don't have the provider overseeing the process. And that's where URAC is getting with this. They don't want to just see ophthalmology clinic, Dr. Y. It's really everybody who's in that clinic that the members make an appointment with should be credentialed. That being said, it's your provider directory that URAC uses to go and choose their providers that they're going to look at. And that brings me to the credentialing of facilities. And I want you to know that when they're looking in the directory, the facilities aren't just limited to what's listed in CR1B, which is acute care, ambulatory surgery, home health, and skilled nursing facilities. If your directory has a DME in it, then URAC's going to choose a DME to review as a facility as well. So I just want you to be aware that what's in your directory is what should be credentialed. The other tricky thing about PCR1 is that criteria for facilities is listed in the interpretive guide of this standard, and it's not very prescriptive. The language in it basically says it may be, the criteria that you're going to use to verify might be, maybe X, Y, and Z. So maybe you'll collect the accreditation of a facility. Maybe you'll get, you'll primary source verify the licensure. These maybes allow you to write your policy and procedure on what criteria it should be. And URAC will follow your policy and procedure. So whatever you write in your policy and procedure is what URAC is going to follow when they do their credentialing file review. And this brings us back to core 3 and what Carole said. What you state you do in your policy is how you implement things. Next slide, please. NCR 7 is a very popular standard that is often not met. It's misinterpreted. What the standard really means is that once the first credentialing person completely reviews the file and it's ready to go to your credentialing committee, there's a second check of that file. You can choose to do 100% of all files or a percentage to do a quality check of a second person. But your policy and procedure should define it, and it's up to you how many of those types of files you want to do. But the point is that I have folks who misinterpret and think, well, I've done the validation of what came in the credentialing application, and now I'm handing it over to my colleague to do the primary source verifications. That's not the second check. It's once the file is complete, there should be a second check. Next slide, please. PCR 13, this can be a little confusing. URAC requires that once the credentialing committee makes their determination of whether a provider will be participating in the network or the health plan, then a letter must be sent out within 10 business days. Some folks are doing both NCQA or URAC, or they have delegates that are NCQA approved. NCQA allows for 60 business days. And this is the major difference between the two accreditation bodies, this one standard. Sometimes you're going to find that NCQA is more stringent. Sometimes you'll find that URAC is more stringent. What we need you to do is just to take the higher ground. Whatever is the most stringent is what you need to take. So if you're going for URAC accreditation, you need to make sure that you and your delegates are meeting the 10 business day turnaround. And now I'll hand this back to Carole. Thank you.
All right, thank you, Lesley. Case management, a few standards. We've been getting a lot of feedback that there's a lot of redundancy in the new case management 6.0 standards. So I will just attempt to go over a few of the high points here. The degree to which an assessment is completed, it has to be at least an RN. The standard requires that the person who can conduct an assessment has to be included in the scope of their legal licensure, that they can conduct an independent assessment. LPNs cannot do this. They can be support staff, but they cannot conduct assessments, as well as not any non-clinical intake staff. They are pretty much limited to the collection of demographic information or making outbound calls to schedule appointments. And I think it was mentioned earlier about licensure. The RN must be, or the case manager must be licensed in the state in which the patient resides. And it's helpful to have multiple licenses, such as the compact states. That's very helpful.
So just to go back on this a little bit, actually, Tom, can you stay on that slide? Sue DiMarino, who is not joining us today. She is one of our experts in case management. And when we were going over the slides for this presentation today, she said, case management, all the standards are tricky, but this one really is the trickiest. And the thing that we find when we go on site is we are finding non-clinical staff doing intake, and that's perfectly fine, as Carole said, but you're going to really need to define and take a close look at what they're doing. We are finding that they are crossing the line for what URAC is comfortable with. So please make sure that you're training staff and management to ensure that you are limiting non-clinical staff. All right, Tom.
So that concludes the substantive piece of this. A couple more details and a tease for the future. First of all, we're going to start posting poll questions, should have just popped up on your screen. This is how we help to customize our services and our webinars to your needs. And so we'd be very grateful if you could just take a second or two to click on the answers to this poll that we're going to be conducting right now. Also, when this webinar concludes, we will send you a satisfaction, kind of a how do we do and how can we improve inquiry, as we do with all of our clients. You're our clients today for this last hour. So we're going to ask how we did and what can we do to be better at it. As if you're new to Integral Healthcare Solutions, as you might be able to tell, we are a consulting firm that specializes in helping applicants for URAC accreditation. You can see the contact information here. You can just write me directly and go to our website, check us out, or give me a call on that 202 number that you can see on the screen. I'd be happy to talk to you about your needs and whether or not we are a good fit for helping you through those accreditation needs. And now for the T's. As we have hinted throughout, we're starting to see some sea changes in the way URAC is interpreting standards. Some of them we've seen for a while, and some of them we have seen more recently. And some of those are for old veterans like us of the URAC world. They're a little bracing and in some cases pretty radical in terms of their level of specificity and how much higher the bar is this time around than it might have been 2 or 3 years ago. So we're going to continue to collect data on these changes in interpretive philosophy and in specific interpretations for each standard. And we're going to build a webinar in the very near future. We haven't scheduled a date yet, but however you found out about this, you can find out about that. We'll let you know that way. So stay tuned. We're going to do a little deeper dive in some of the very specific ways that URAC's change in interpretive philosophy is impacting specific interpretations of standards. We're seeing it really across the board. As Lesley said, we're also anticipating in 2021 some significant revisions upward. We're guessing, and it's always a guess, we're guessing that we'll see Health Plan and Health Network 8.0. We're guessing that we'll see HUM and Workers' Comp UM 8.0, and some other major upgrades that will basically weave in what has been the core 4.0 standards into these new upgraded modules. And then I'll say one last thing about it by way of tease. One of the things that's quite clear from the new generation of URAC standards is there's going to be more emphasis on the desktop review submissions. So a lot more validation is going to go on, sorry about the airplane, a lot more validation is going to go on at the desktop review level, and much less on the validation review level. So that's part of why we're seeing more stringent desktop review standards, is because some of the new standards don't even have any validation review activity associated with them. They're entirely validated during the desktop review stage. So, and we'll cover those kinds of issues as when we do our next our webinar in the near future about the new standards and the new interpretations.
sometimes when we just see a jump from a small jump in a module for three, especially pharmacy 3.0 to 3.2, a client will say to us, but it's the same standard. They didn't change the language of the standard, so we're not meeting it. We don't understand why we're not meeting it. We should be submitting the same thing. So I just wanted to tell you that some of these standards have not changed in the new versions, but the expectations have changed because of the validation requirement during desktop review. So you do need to submit more. And we are going to tell you to pay special attention to what they're asking you to submit. They're asking you to submit more.
I think I'll close with this, just so you know, well, how do we know what's a hard standard? Or how are we analyzing this new interpretive philosophy? Whenever one of our clients gets a request for information back from URAC, we analyze every single comment that URAC says to figure out if it's a new interpretation, or if it's an old interpretation and that we missed, or if the client missed something along the way or didn't listen to us, our suggestions, and then we plug all of these in to it's actually one of our quality metrics that we measure how well we did, and we also can quantify what percentage of these are these differences that come back on the RFI are URAC revisions and interpretation. And so what we've noticed lately, I guess is what we're telling you, is that we've seen an increase in the percentage of RFI comments that are simply new interpretations. So as Lesley said, don't rely on what you did last time. And the other thing that we do with that information is that if we're finding out that there is a new interpretation, we will revise our tips and tricks, which you can see on our website and which our clients can see in our Goldfinch application. We will revise those tips and tricks to reflect the new interpretation that URAC has. So it's one of the ways that our organization stays on top of the ever-changing landscape of URAC. I think that's it for this time. Again, please fill out the viewer satisfaction survey we'll send you shortly. We'll also send you a link to this broadcast on our YouTube channel, and write K Petersen with an E at the end, KPETERSEN @integralhs.com if you want a copy of the slides. Thank you so much, and we hope to see you next time. Be well.